Today I will be discussing our surgical technique for the treatment of an osteochondritis descendens lesion of the lateral trochlea using a Macy scaffold and proximal tibial autologous bone grafting. There are no pertinent disclosures. The patient is a 16-year-old male club soccer player with left-sided lateral knee pain for 2 years without any inciting trauma. His pain is worse with deep knee flexion and has persisted despite physical therapy and activity modification. He was found to have neutral alignment when standing as well as a stable knee ligamentous exam. Upon review of his MRI, there is a 14 by 13 millimeter osteochondritis descendens lesion within the lateral trochlea that correlates with his area of pain. The patient underwent an initial arthroscopic procedure that showed a full thickness cartilage defect and also a roughly 5 by 10 millimeter fissure that probed deep into the subchondral bone. At this time, it was determined that he would be a good candidate for a modified Macy sandwich procedure and a cartilage biopsy was performed. We used a large ring curette to harvest hyaline cartilage from the interchondral notch. After sending this biopsy to the variceal processing facility, chondrocytes were extracted and uniformly seeded onto a resorbable collagen membrane known as the Macy scaffold for the second stage. For the second stage, we began with a diagnostic arthroscopic exam which confirmed the lateral trochlea OCD lesion. We then proceeded with the proximal tibial autologous bone graft harvest. A roughly 3 centimeter incision centered over the pes, just medial and inferior to the tubercle is made. Dissection is then carried down to bone and retractors are placed to ensure adequate visualization. The 10 millimeter Arthrex osteoauger is then used to ream and harvest approximately 8 to 10 cc's of autologous bone graft from the proximal tibia. The harvester is uncoupled from the osteoauger system and the bone graft plunger is inserted into the distal end of the harvester to push the already mortualized bone graft out of the proximal end. The bone void in the proximal tibia is then filled with cancellous allograft bone chips under direct visualization. Attention is then turned to the open treatment of the OCD lesion. A roughly 8 centimeter incision over the lateralmost aspect of the patella is made and a lateral arthrotomy is performed to access the lateral trochlea. The OCD lesion is visualized and the lesion is provisionally debrided with a ring curette. The sizing templates from the JRF osteochondral allograft instrumentation tray are used to measure the defect. A 16 millimeter sizing template completely encompasses the defect and 2.4 millimeter Kirschner wire is placed centrally through this sizing template. Sizing template is removed and a standard 16 millimeter reamer is used to ream to a depth of 5 millimeters. In this case, upon reaming to 5 millimeters, it was noted that there was a deeper area of abnormal sclerotic bone, so a 12 millimeter reamer was used to ream centrally to a depth of 8 millimeters. At a depth of 8 millimeters, the entire base of the lesion showed bleeding, healthy cancellous bone, so no further reaming was required. The Kirschner wire is then removed. Attention is then turned to the Macy scaffold. This scaffold is a single layer scaffold with a sheet-like appearance. The JRF ortho scoring instrument is used to cut a 16 millimeter diameter circle of the Macy scaffold, as shown here, resulting in the scaffold here. The autologous bone graft initially harvested from the proximal tibia is then packed into the previously prepared osteochondral defect. Fibrin glue is then applied to secure the graft. The Macy scaffold is then placed onto the base of this lesion with the cell side facing towards bone. This is again secured with fibrin glue, and at this time it is optional to further secure the scaffold with 6/0 vicryl sutures. The knee is taken through a passive range of motion test in order to ensure stability of the scaffold, and the wound is closed. The patient is to remain toe-touch weight bearing for 4 weeks with the hinge knee brace locked in extension. Full weight bearing is allowed at 4 weeks postoperatively. The knee brace is unlocked at 6 weeks postoperatively when the patient demonstrates sufficient quadricep strength and control as well as proper gait mechanics. And a continuous passive motion machine is given to the patient at 4 weeks postoperatively to be used for an additional 6 weeks. Thank you.